Hello and welcome everyone to today's Spotlight Series episode. My name is Tanya MacDonald and I'm pleased to be your host for today's session. I would like to remind people that this session will be recorded. I'd also like to start by saying that I am hosting today from HEC's offices that are located on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. I recognize the privilege that I have living in this city, and also as part of my journey towards truth and reconciliation, I'm committed to learning and unlearning more about the history of our country, and really focused on learning more about Indigenous ways of learning and across the health system in particular. We are also very pleased today to offer French simultaneous interpretation provided by Boost Events, a subsidiary of Boost Lingo LLC, for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen, as today's session will be hosted in English. If you do not see the interpretation menu on your screen, please select the More button menu and select Interpretation. Now to share a little bit more about our Spotlight series. Our Spotlight series is really an opportunity to have a focused, constructive discussion and explore solutions to support improvements across the health system as we work together to shape the future of quality and safety in healthcare across the country. Today's session is entitled Working Together for Better Care, Benefits of Health and Social Care Partnerships. Integrating health and social care can improve equitable access to care and provide unique opportunities to address the complex health and social needs of people, as well as the complex system challenges that we're experiencing today. During today's webinar, panelists will share the impact of these partnerships and their experiences of working together to make a difference. We invite you to share your questions and comments at any point during the discussion today using our chat box in either English or French, and we encourage all of you to respond to comments and answer questions in the chat along the way as you wish. We have a large number of registrants for today and we expect many questions, so we will do our best to make sure that we answer all the questions that come through. However, we may not have time to respond to all of them. If you need any support at any time during this webinar, you can reach out to one of our producers using the chat feature. And we also want to make sure that you take good care of each other and that we take good care of ourselves during this session, recognizing that some of these topics may be difficult for some of us to hear, to learn, and to share about. I invite you to bring in the foreground what helps you feel grounded and safe. We invite you to do what you need to do to stay well, including taking care of yourself, taking breaks when you need to. We also have some mental health resources that we are sharing in the chat to support you along the way. As I introduce our guest speakers, I'd like you to also please take a moment to share, introduce yourselves in the chat box. So joining us today, I'm pleased to introduce Jill Gerke, Director, Regional Community Programs at Island Health, Nikki Page, Manager, Housing and Shelters, Victoria Kool-Aid Society, Nikki George, Indigenous Leaders Model Health Equity and System Transformation, Ontario Health West Region. Nikki also has a previous role with Indigenous Navigation Services in acute care, and Louise Bird, patient, partner, and caregiver. So now I will invite our four panelists to turn on their cameras and that they can have an opportunity to introduce themselves a little bit more thoroughly than what I just did. So Jill, we'll start with you.
Thank you, Tanya. Good morning or good afternoon, wherever you are in Canada. My name is Jill Gerke. I'm very pleased to participate and be part of this conversation and this discussion. I'm coming to you today from the beautiful lands of the Coast Salish people on Vancouver Island and the Qualicum First Nations. I am the Regional Director for Palliative and End-of-Life Care and Regional Community Programs in Island Health. But that's just a small piece of my role. I have spent probably the last 35 years working in community-based organizations, predominantly in Alberta. And so I have a real passion for community care, for community-based programs, not-for-profit. And so when I came into Island Health government agency, our big healthcare system and big engine, it was really important to me to kind of continue to bring that thread, that voice, and continue to shine a light on the role that community organizations and community programs can play in healthcare. So thank you. I'm really excited about the conversation today.
Thank you so much, Jill. Now I'm going to turn over to Nikki Page.
Thanks, Tanya. Hello, everyone. My name is Nikki Page. I'm a housing and shelter manager here in Victoria, BC. I'm incredibly grateful to be able to join today's session from the unceded territories of the Lekwungen speaking people, the Wasanik, Songhees, and Esquimalt nations. I've lived in this city basically my entire life, and I never don't give thanks to the grandmothers, grandfathers who came before me, the grandmothers, grandfathers, aunties, and uncles who will come after me, who have taken care of the land and the people on it since time immemorial. And thank you for giving me this opportunity to be here and participate. I came into this work a little bit different than some, and I actually was pursuing a career in the medical field and realized that just didn't feel right for me, and had this opportunity to come into social services where I've really been able to see the benefits, but I've also been able to kind of identify and navigate through gaps of our healthcare system when working with impoverished and unhoused individuals. And so, like Jill, very, very excited about this topic and the conversation, and not only what I can share, but also what I can learn and take away. So thank you.
Thank you, Nikki. And now Nikki George.
Thank you, Tanya, and good afternoon, everyone. My name is Mishko Benezikwe, which means Red Thunderbird Woman. I am from Kettle and Stony Point First Nation in Southern Ontario. I live close to my home, not too far, and my entire career has been working with Indigenous communities, particularly a large portion of that was doing nutrition and health promotion, developing programs, and assisting communities in running programs and services. And so more recently, I spent some time in acute care, which was a really great experience for me, working alongside patients and families. And so I think I will be leveraging that experience very heavily today, and what I've learned and experienced over those experiences helping folks. And just recently to Ontario Health, so a total different stretch of work. But thank you for having me here today, and I look forward to discussing.
Thank you so much, Nikki. And now Louise Bird, please introduce yourself.
Hi, everyone. I'm Louise Bird. I hail from Carlisle, Saskatchewan, Treaty 4 area. I am a patient partner, caregiver. I'm a breast cancer survivor of 22 years and a current caregiver for my husband who has CKD. Thank you for having me, everyone. And I really look forward to this series.
Thank you so much. And so as you can see, our panelists have actually a wealth of experience navigating the healthcare system. So really looking forward to this conversation. And just a reminder to the people who are joining us today, this is actually set up as a discussion. So there are no slides that we'll be sharing as part of the conversation, but really just an opportunity to engage with all of our different panelists on their experience navigating the health and social care system across Canada. So the first question I'm going to ask Louise. So given your experience with the healthcare system, both as a patient and as a caregiver, accessing health and social services can sometimes be difficult, as I'm sure you can attest to through your experience. It's also made more difficult when our basic needs are not met. Can you speak to your experience in understanding what services were available to you, are available to you currently, and your experience accessing both health and social services to support both you and the person that you're supporting along their journey?
Thank you, Tanya. It's interesting because unfortunately, the landscape hasn't changed in the last 22 years from when I was a patient. Yes, there is more navigators, but are they always available for patients? When I went through breast cancer 22 years ago, I would say I was stumbling in the dark. They thought it was fine because I didn't crack until towards the end of the first time I had breast cancer. And so the menu of supports really wasn't made too available. There was some of them that I knew what was there, but when I first walked into the cancer clinic, they handed me an 8x10 envelope It was jammed full of pamphlets and stuff. I wasn't ready for that envelope. I took that envelope home and threw it in the drawer. And it was only until after my 5th chemo appointment that I actually looked at it. And the next time I went for an appointment, I started asking about some of the stuff available. However, I lived in rural Saskatchewan. I was 2.5 hours from Regina. There wasn't a lot that they really could offer, except some phone support or counseling. And throughout my survivorship journey, I found that still is a stumbling block. I've talked to people on a pan-Canadian basis, as I sit on many different committees and still sit on committees. And unfortunately, that is true. And for someone my age, I will be 59 in October, we were always conditioned not to ask for help. It was a bad thing. You only deal with a social worker if you need income support. Well, that's not true. They're a wealth of knowledge, and working alongside your social worker who's offered to you is often the only way you get to really truly see what menu of supports are available. I support my husband who has CKD, and that's the only thing that's kept me sane, is working with the social workers through the kidney dialysis program. The bad thing is we're now attending home hemodialysis school. We're learning to do dialysis at home. And so we have a new social worker. I've only had one problem with one of the social workers when my husband was first in the hospital. I had to ask for a new one because I didn't feel we were being properly supported. But I can tell you that the menu is there, but we need to have a menu that looks at the whole. The patient is a person. A person is more than just a diagnosis. You need to look at the whole: mental, spiritual, physical. Do they have a house to live in? If they don't have an income, how are they surviving? And so there's lots of stumbling blocks and lots of hurdles and barriers that you have to tackle. And for anybody who doesn't live in a major center in Canada, it's harder to get the services you need. And some services, I can honestly say, just don't give a rat's you know what. So that's my take. Thank you for listening, and I look forward to more questions.
Thanks, Louise. And I think that your story has been resonating with some of the people who are listening today about just that experience with being handed information at a time where maybe you weren't ready to receive that, or it wasn't the right time, and that actually you needed additional support to start off on that journey. So Nikki, George, given your experience, and we heard Louise touch on the role of navigators, and you have lots of experience in that space, and 20 years experience in health and wellness and community program planning and development in rural settings and First Nation communities. So what part of Louise's story resonated with you? I mean, when you hear her say nothing's really changed, and I think you said 20 years, Louise, potentially, how does her story sit with you, and what resonates?
Yeah, thank you for that. And thank you, Louise, for sharing your story. And storytelling is so powerful. We learn so much from that. But in fact, her whole story, there was so much that resonated with me. And I think the first piece that really came to me was, oftentimes we as caregivers or people that work in the system forget the stress that this is put on patients and their families. And I think myself, as we often need to be very in tune to social determinants of health and all of those pieces that impact patients and caregivers. And we need to look at those and build those into how we address the care and supporting them. And certainly, especially when you're looking at complex needs. I always say complex needs need a complex approach. And what I mean by that, it's like one person cannot support and think they can provide all that patient and caregiver needs. So it takes a team approach. It takes community approach to support and wrap services around folks. And I heard Louise talk about rural access to care. Certainly, again, many of patients that I have, patients and families I work with that live in rural, it is more difficult to access services. They often have barriers such as, just transportation that many of us take for granted. Transportation. There's also fear around accessing service for Indigenous folks. There's fear around, discrimination, racism. There's fear around, are they going to take my needs seriously? Am I going to be taken care of? And I'm so glad to hear Louise talk about holistic care. And I truly am a believer. I live it, that holistic care is detrimental to providing the best support and care for individuals. And that is truly looking at a person as a whole, not just their physical needs, because oftentimes healthcare, medical care looks at those physical needs. So, I think about patients that we discharged from hospital, a lot of it was around physical needs, what services they need, what equipment they need, do they have transportation, but we really need to look at emotional, mental, and spiritual. And, and that's truly key for Indigenous population. That's a belief system as part of our culture is to treat the person as a whole. And we don't achieve balance in our life unless all of those pieces are in equal. So the other piece, I want to say is, a lot of, Louise mentioned being forwarded a lot of information very early. And I'm always very cognizant, and this is also another social determinant of health, is health literacy. I myself find it difficult to navigate the healthcare system. And I have that health background. So just being cognizant that for many people is so difficult when you're handed, a package of information and trying to sort through and understand and help and navigate. So yeah, I said a lot, so I want to, I'll stop there, and probably some of my other colleagues on the line will want to share. Thank you.
Thank you, Nikki, George. And I really like that addition of health literacy as a social determinant of health, because I absolutely think it's key, in terms of how we share information, how we present information, and how it's received, and doing those checks to make sure it's actually accessible for people. And I think all the pieces that you touched on in terms of social determinants of health, and that there are complex needs and that require complex solutions, and that really grounded team approach, which actually leads nicely into the question for Nikki Page. And I'm going to weave in the question that came in from Chandon in the chat about, so given your experience in terms of working with absolutely complex people with complex needs and vulnerable situations as a housing and shelter manager at the Victoria Kool-Aid Society, what are your perspectives on what it looks like to provide holistic care, and weaving in those complexities around social determinants of health, and any other suggestions you have, in addition to expanding on what we've been hearing so far in terms of that complexity of care and that need to take a look at that holistic approach?
Yeah, thank you, Tanya, and thank you to Chandon for kind of bringing that up. So as I mentioned kind of in my introduction, I'm really lucky to have stepped in both worlds. I had a very brief kind of opportunity to see the medical system and how, the Western medical model works. And kind of on my journey to where I'm at now, I've had a lot of opportunity to see what does it. And, I think there's a lot of things that the Western medical model does very, very well. But I absolutely have to echo what my colleagues on the call are saying, in that what we're really lacking is that holistic wraparound support. And certainly working with an unhoused population who struggle to meet any of their basic needs, you kind of put healthcare on there, and that's really not a priority in that moment. Survival is the priority. And so, I think working in a setting that's so closely linked to healthcare, but is also kind of considered removed, is a really tricky place to navigate. And I think if you talk to anybody who works in the social services in a frontline capacity, they'll tell you that we are more overrun with gray in terms of there's not really there's not really legislation, there's not really regulations, there's best practice and what we can do with a very limited amount of resources. And so I think in terms of that piece of tying them together, there's so many more resources we need and don't have access to. And I fundamentally think at the bottom line, understanding that housing is a health need, and as much as medication, as much as food, as much as water, these are health needs. And also listening to the person, because as much as I think housing is important, there are going to be individuals who don't want to be housed. And so how do we listen to them as experts on their own lives and integrate what they want and how they're going to succeed with what we as a societal, with a Western medical lens, think that they're supposed to have, and balancing that and putting the person first is always going to be the best approach, right? We know this. In terms of how this has worked in my role in integrating services, it's work in progress. It's always, I think, going to be work in progress. I don't, we have turnover, we have to rebuild relationships. And while the organizational relationships might be there, the person-to-person one isn't always there. And that's equally as important. And I've been incredibly privileged to have been able to sit with really like-minded individuals working with a very common goal. And currently that common goal is palliative care, and finding a way to bring palliative care to the unhoused population, but really reframing what we think palliative care looks like, and reframing the idea that palliation means a terminal illness, means death, means they're going to pass soon, and shifting to a palliative approach, which really, really mirrors a harm reductive approach, which is what we do in my particular workplace and often in the social service sector. And so having that opportunity to work with like-minded individuals from different organizations and different sectors within the greater, service provision as a whole has been, I think, foundational in my ability to say, okay, so this is what all of these people are identifying as a need, and this is the population I serve, and how do we bridge this? And I have the opportunity now to learn from brilliant minds and to be part of a solution, which is, I think, really neat when we're kind of in this crux time where we really can make difference and impact. And why not start from the bottom and get the answers and get, meet with the Louises of the world who can tell us what we're missing and where we're faltering, and take that and actually learn from it, heed it, and apply it universally, so that we're looking at a person as a whole and not a person as a number or a person as a bed. Yeah. I think I'll leave it at that.
Thank you so much for sharing that. And I mean, we can hear the absolute passion you have for the work that you do, and also that real grounded importance of integrating health and social based on the person's needs and what they need in terms of their own wishes with respect to care and where they receive care and how they receive care. So leading nicely into Jill Gerke, as well as your passion both for palliative care and given your role at Island Health, where you have a more health system, health authority role. And we know you're very passionate about palliative care and for those who are structurally vulnerable. Can you share with us how important it is to have these relationships with community-based organizations to provide that integrated lens with respect to care? And specifically with the Victoria Kool-Aid Society.
Sure, thank you, Tanya. And oh, my wheels are turning as I listen to my colleagues and I think as we started off with Louise, really grounding us in the essence and the why, the work that we do is so important. Partnerships, I think in particular the one that we have with the Victoria Kool-Aid Society and my early work with Nikki and her team, I think is so integral to the health authority in Island Health and our health system, because what it does is those relationships with community organizations, particularly Kool-Aid, provide us the opportunity to really have the individual, the client, the patient, the family, chosen family, whoever that is, at the core of the work that we're doing. In our health system, as you all know, across the country, we are siloed. We are based on programs and structures that create barriers to access and how information is shared. And so the opportunity to partner with community organizations begins to kind of settle that or dissolve those barriers, and allows us in the health system to work towards the edges, to push a little bit around what is possible, to think outside of our constraints and policy and practice and process, and move to the edges to be innovative, keeping the client, the family, chosen family, and in essence, the community that is wrapped around, particularly our structurally vulnerable populations in the inner city, keeping them at the core of our program planning and service planning as we go forward. And I think what we've learned over the last number of years in terms of the work that we've been doing in the Greater Victoria area, particularly around the Port Palliative Outreach Team and our partnership with Kool-Aid, that work was grounded in community and in inner city organizations through the development of the inner city action teams. And those inner city action teams were representatives from community organizations, not the health authority, coming together to identify what are the gaps, what are the barriers in really real ways. And then through the facilitation, and we had a unique opportunity and continue to have a unique opportunity with Dr. Kelly Stajahar, the UVic Center for Aging, and her work around equitable approaches to palliative care. As a research team, they facilitated the coming together of these inner city action groups and action teams. And that really provided the kind of the launching point for the development of our partnerships with community organizations and in particular Kool-Aid. So I think I can't say enough about how important those relationships are, but at the crux, at the kind of the core, is it really brings the individual, the patient, the client, the family to the center of all of the work that we do. In our health system, we're bureaucratic, we're stuck in process, and that slows everything down. When we can partner with folks like Nikki, have patient voice like Louise at the table, we can make things happen. And so that's why it's so incredibly valuable.
It's really nice to hear you share that example of where it can work and it works well. And I think we just need to have that trust and build those relationships between health systems and community-based organizations and know who the right team or organization is to deliver that care in a meaningful way, and always keeping in mind to put the person at the center. So it provides a lot of hope for what we can achieve as a healthcare system across Canada. So Louise, I just wanted to circle back to you and thinking about your journey and your experience, and maybe you didn't experience really well coordinated care, but from your perspective, what would good integrated holistic care look like for you, and have you experienced that? And can you talk to us a little bit about that, either through your journey or as your journey as a caregiver?
Okay, well, I have both a nursing and then after breast cancer, a special education is where I worked. And it's interesting because the systems some provinces have better development of systems, and they realize that healthcare isn't square, it's ever evolving. And you do have the patient and the family at the center. Unfortunately, not all provinces are there yet. They have to recognize that the patient, family, and the spectrum of needs that they may need it's really hard, especially when you don't live in the city and you're out in the rural area. Because what's available is often a hidden secret. So I think there's got to be more focus, and everything has to be more upfront, more knowledge. The general public needs to be better knowledge of what supports are available. And that seems to be a stumbling block. A lot of people who live in a large city have never left that city. So they don't know what it's like when you don't live in the city, and they're stuck in that mindset. So what I've found is I've experienced great care as both a patient and a caregiver, and I've experienced really bad care as a patient and caregiver. And I've listened to other people, other patients, caregivers, even people who are practitioners, because Canada's got to we have to have a pan-Canadian strategy. So everybody's on the same page and everybody has the same level of knowledge and can share the same level of knowledge. And healthcare looks very different right across Canada. We have silos, we have regions. So I think there's got to be continuity, and we need to have some sort of strategies that are the same pan-Canadianly, because only then will we start to see a greater change. And the change may not always lose the isms, racism, ageism, and how people perceive those who are homeless, but we'll be on a greater learning curve and we'll be reaching those goals. I know it sounds lofty, but I think that's the perfect health, economic, spiritual, holistic care strategy that we could have for Canada. So just my words. I'm looking for somebody to build on this. Thank you.
Thank you so much, Louise. And I couldn't agree more that we do have a huge opportunity here to look at health more holistically across the country. And then shifting over, although it is a lofty goal and aspiration, given that we do have different systems across all the provinces and territories trying to achieve these lofty outcomes. So Nikki, George, just thinking about your experience and how you support people while they're going through difficult times, and that each person has a unique care journey and experience and need and view of wellness. In what ways have you been able to support people to address their needs and improve their well-being through their journey so that they do experience those good care moments, as Louise touched on, and not necessarily, maybe more of the good and less of the bad?
Awesome. Thank you for that question. And I think, and we've heard it here from colleagues before, and Louise, and I think in my experience, I don't think this is something new, but it really is taking a person-centered approach is key, is what that person needs, not what I think they need, but what that person needs is going to help build a plan that is sustainable and going to support them. Have to understand that person and family, their strengths, the barriers, and that will help create success for them. And in addition to that, my experience has been, especially with complex, and I did mention this is a team-based approach. I've always liked that saying, it takes a village, right, to raise a child. And with some of the complex needs, it takes a team-based approach to tackle and support patients and families so that they have great outcomes and good patient experiences, honestly. And so that is, working not within just your organization, but working with community partners. 100%, I think of probably 90% of clients that I have assisted through navigation. The handoff, there was always a handoff to community supports and working with community supports to support them. Because once they left acute care, I wasn't as much involved, but, having my community supports, having them wrap around folks was really, really key for them. And it kind of went the same, they come back into acute care system. My partners, you know, were able to share, this is what we were working on, and invite those partners to come to acute care to support as well. Another big piece specifically for Indigenous folks was really embedding culture. And we know many Indigenous people have lost that culture and they're trying to get back to culture. So culture, we know, is key to success. You know, especially when we want to look at the whole person. And a lot of times that can look like getting them to a ceremony that they need, getting them to an elder or healer that can give them some spiritual advice, lead them on spiritual journey, support their mental, emotional pieces. But that holistic approach, and I don't want to say that, you know, on its own, it can be in tandem with Western care. And oftentimes when we couple those together, seen really good success outcomes. And I want to give one example to a patient that I supported who was homeless and also substance use. And you know, we were able to rally around him supports within acute care. We reached out to community supports, his First Nation, mental health supports, housing supports, included access to culture, traditional healing. And, you know, that was a true success story. And it wasn't, you know, I can't imagine that just one aspect of that whole plan could have really helped him become successful. It really was a complex approach in wrapping those supports around him. And yeah, so I think, again, like I think my colleagues have said, is you know, really understanding that individual. And oftentimes how I approach that is, you know, how can I help you? Not me offering all the time. You tell me how I can help you. What is it you need? And we work together. It's a partnership, and we walk together that journey and support them the best way we can.
So what I'm hearing from you, Nikki, is also that key to the relationships between the health system and the community. And can you share more a bit about how you go about building those relationships so that you're able to provide those meaningful wraparound supports based on the unique needs of the individual? Because I think that's key from what I've been hearing, and from Jill and Nikki Page's experience.
Yeah, for sure. You know, it is, you know, number one is recognizing that these health issues need this type of approach. They need a partnership and collaboration approach. And it, you know, it is that, you know, reaching out, starting to build that relationship, connect with, and I think it was Nikki Page that said, you know, connect with those folks that are like-minded, the ones that, you know, that you have that common goal. And so I think that the other piece was, you know, that reach out initially might be a handful of people, and you just have to, you know, be open-minded and innovative and allow that those partnerships to grow too, because there are other folks in the community that will be able to help. So I guess keep being open-minded and allowing your partnerships to grow to best support individuals.
Thank you. And Nikki Page, you know, thinking about the different wraparound supports that Nikki George shared about how, you know, it's housing, it's health and social, it's the spiritual needs, it's also the physical and the medical, and you're absolutely embedded in that work and in partnership with the health authorities. So how does it feel from a community-based organization's perspective to engage in partnership in relationship with a health authority, and how was that received, and how was that built from your perspective?
Amazing question. I actually really love this question because I think it speaks to a place that probably myself and a lot of the folks on this call are on, where for my situation, that relationship was already established. There was already a working relationship between the health authority and my organization. And so, you know, it's that turnover piece that I talked about. The relationships exist organizationally, but they don't necessarily between people to people. And so, yeah, so my experience has been, we'll say, varied and vast. I first really want to thank Jill for bringing up that action team. And when I was talking about that hive mind collective, that was actually the opportunity I had, was to join that action team. And so the organizational relationship was there between Kool-Aid and the health authority. And that was my opportunity. Joining that action team was my opportunity to collectively hear from people who weren't the health authority and establish the relationship with other service providers as well as the health authority. And we were able to, have amazing guidance from Kelly and from Ashley Mollison, and to be able to find really great ways to integrate the ideas that we had with the existing services, with the support of the health authority, which we need. Fundamentally, we need their support. To be honest, we need their money. That's a little bit of it. And working with a staff team who supports people who have been let down by the healthcare system a lot. There's a lot of hesitancy, and there's a lot of really guarded approach where the distrust of, are they going to meet the needs of this person that I care about? This person that doesn't have housing, doesn't have, and that's the one thing I'll say in terms of kind of my connection here, is that I'm not even in housing support. We're supporting unhoused individuals who have not gained housing. And that's in itself a really revolving door with a lot of systemic limitations. And we know there's been systemic oppression towards folks. And I'm really resonating with, I think Nikki George said, complex needs require complex supports. And that's really resonating with me, because that is what we see. And it's very challenging, I think, to navigate what those supports look like when the people with the complex needs are not, they're really examined just under that medical lens, or just under this social determinants of health lens, or just under this what can we do in social services lens. And we have to integrate. And we've had really amazing opportunities by having these relationships. We know a disproportionate number of unhoused folks are dying. And so this particular relationship with Jill, and the work being done with the action team, and the support of healthcare excellence, we're able to examine this and not only see how every single person that we get to work.
I think we may have lost Nikki Page's internet feed.
Oh, and it was so good where she was.
I know. I was like hanging on her next word. So maybe
Yeah,
we can transition to Jill, because what I heard from Nikki Page before we lost Nikki was really, what I'm understanding, because you both work closely together in terms of this health authority and community-based organ. There's a lot of, oh, Nikki's back. Did you want to finish your thought, Nikki?
If I don't know where I left off, but one thing I wanted to just touch on really quickly was throughout the pandemic, we saw the creation of more outreach teams, and we saw more medical services coming to us and breaking down the geographical barrier. And so one of the biggest benefits is that healthcare is starting to come to the people where they are, instead of expecting them to go where healthcare is. That's boosting the confidence of the social services sector, that the healthcare sector really does have this investment and want to support us, and that we can continue to grow collaboratively instead of continuing these silos. It's going to be a lot of work. And I want to just really emphasize that this doesn't happen overnight, and these relationships aren't formed, drop of a dime. They take time, they take commitment, and they take, a little bit of that fiery passion inside you to push back where things need to be pushed back against. So I'm going to try and fix my connection while Jill gets to talk.
Well, we heard you quite clearly there as you finish your thought. So we're grateful that you were able to finish that thought. And for me, it's actually a nice lead into the next question for Jill. I mean, I hear the importance of these relationships. I'm sensing that there's a shift, that we are moving forward into that more meaningful integration of health and social services. And what I'm also hearing is that it's grounded in reciprocity. We actually need each other to be able to meet the needs of the people that we're serving, or that people who need care. And so what does this look like for you, Jill, in terms of it's important and why it's clearly a priority for you. So if you could talk a little bit more about that grounding and reciprocity between the two organizations. And to Nikki's point, like, it's helpful for that health system funding for sustainability, and then also it provides the health authority an ability to reach people that potentially would not reach.
Oh, there's so many different thoughts going through my head, and I'm mindful. I have a lawnmower outside my building, and I apologize if the sound is not great. I think a couple of things are coming to mind, and I actually would like to go back to some comments Louise made earlier. You are so right, Louise, when we talk about the variability across the country, the variability in access across the country, the variability in navigation and access across provinces, within health systems, within territories, and then within cities and rural and remote. And so how do we address that, I think, is, such a fundamental question. It's part of, I think, Health Excellence Canada, and this collaborative and this collective is really trying to move us towards. But I think it is so important, and there's pockets. On Vancouver Island, we have pockets of really phenomenal engagement and partnership happening in various areas, but it's not everywhere. So I think that's the opportunity. When we think about the partnerships and the structures and what we need to have in place, if I bring it up just a little bit to kind of that health systems perspective, one of the things that I think is critical and vital is that community partners need to be at the table at the conception of ideas and service planning in order to move us to a place where we have those interdisciplinary team-based approaches, Nikki, George, that you've been speaking about. We actually have to have community partners right at the table at the start. And I think we are evolving in our health authorities and in our health systems around inviting community partners to the table. And I think we are evolving in a good way, albeit slow, but having community partners in our clinical governance structures, in our planning, at our planning tables. So for example, in Island Health and the palliative and end of life kind of program clinical governance structure that we have, we've had community hospice organizations at the table for as long as I've been around, because we know the value that those community hospice organizations bring in terms of they're part of the care team. They're part of an individual and a family's experience of moving through diagnosis, anticipatory care into bereavement care. And so in the same way, when we think about our relationship with Kool-Aid, the Victoria Kool-Aid Society, it was you just had to have them at the table right at the conception of how do we improve access to good palliative care for individuals who are unhoused, who are vulnerable, who are inner city and don't know how to navigate, as you say, Louise, the system. And so again, I have to give credit to Dr. Kelly Stajahar and academia and research, because they actually were the conduits. They were that center entity that brought everybody together and really taught us. So, from a health system, health authority perspective, I was so grateful to be invited by Kelly and her team. And then I had to just surrender and listen and learn, and not be the almighty health authority that said, yeah, we can't do that, or yes, we'll take that and we'll run with it. I had to just kind of go, yeah, this is magic what's being created with these inner city teams, with these partnerships. And so what can I do to remove the barriers within our health system to allow this this energy, these programs, these services, these collaboratives to foster. And so I think from a health systems perspective, and how we move to success in those, it's about the health authority stepping back and learning from our partners.
Great reflections, Jill. And I can see from the comments coming through in the chat that this conversation is really resonating and also providing some guidance and advice to people who are already engaging in these conversations between community-based organizations and health systems and how they can move forward together. And what I've also heard from you, Jill, is that it's really important to have everyone at the table from the start, at the design, and not bring them in when it's too late. Whether it be patient partners, people living in community-based organizations, that everyone together needs to be there from the start. So my next question would be for Louise. So from your perspective, how would you like to be engaged in these conversations from the start in the design of these programs and integrated health and social services as that person representative from the community?
Yeah, thank you. And thank you to my colleagues for all their words of wisdom. I have been engaged at the table for talks, and it's all about a strategy planning. And you work as a team, you're integrated, you become colleagues, and you all have input, and you all listen, and you all share. And that's the only way that we learn from each other, and that's the only way that we can build a stronger network to ensure that these community-based needs are met along with healthcare. As I said before, it's like a revolving door. It's an evolution of needs that the person, the family, has to have to succeed. And you have all these partners working together to provide the best possible care possible. And you can jump on the spectrum in any aspect. You don't just have to start as a patient. You can have your caregiver phone and say, hey, what supports are available? And then through the strat planning, people who have been engaged know that it's a bigger picture. It's not just a little one slice of the pie, it's the whole pie. And it's the whole pie that people can learn, that they can have access to. And you work hand in hand. Community partners work with funders. Funders work with community partners, patient partners and caregivers give input as to what they see happening, on a pan-Canadian basis. You bring it to the table, so we don't reinvent the wheel. We implement the parts of the wheel that are working in other provinces to build stronger networks throughout Canada and throughout your home province. Just my thoughts. Thank you for listening.
Thank you for sharing, Louise. And I absolutely agree. There is so much good work happening across the country and lots of great strategies that are already being in place that we should absolutely not reinvent the wheel and learn from the good that's happening and obviously adapt to whatever context or setting that we're working in to make it our own. 100% agree. And this is a great opportunity to share those insights and through all of your experience in integrating health and social services. So Nikki George, you've supported many patients navigating care and thinking about all the people that you've helped across their journeys. What made their care better? What stood in their way for them accessing really good, great care from your perspective?
Hi there. I think a couple of things really I'm thinking about, and I've heard it already, and this is something I often use with colleagues, and it is listen, learn, and act. I think when we are really able to listen, not just hear, because they're two different things, but really listen to the needs of those patients and caregivers, then we're able to reflect, learn, and give us some direction into where we're headed. And a lot of access issues for patients and families could not have been overcome without partnerships, without community partners. So I want to kind of go to, what I was trying to think about, how how did we strengthen that marrying sort of the health and social systems. And I think a few things that really was helpful, and that's awareness that something else needed to happen. What's the problem? What's the risk? So and then being able to make adjustments to how we do things. Like, I think we need to push the envelope a little bit and ask questions. Why are we doing it this way? Why can't we do it this way? And with that, it's just being able to be flexible and align things differently to meet the needs of patients and families across the health system. And certainly there's always a piece of advocacy that comes along with that. So back to, when we were developing partnerships with other organizations, and not just limited organizations. Who are those other people that need to be there, that have invested interest in the issues? And sometimes that's allies. It's the clients and patients. It's workers in the system. It's researchers. So really being open to having a cross-sectional group of folks to tackle some of these complex problems. So I hope I answered that appropriately. I had so much in my mind I wanted to share, but I think, combating access is really around, again, a pivotal, really easy first step is really listening and learning from the folks that are experiencing that, because they're going to help drive the path forward.
I love that, Nikki. And I also highlighted in my own notes that access is about community partners. I think that not one organization can do it alone. It really does take a community, a village, a system to support those unique needs of individuals. And so that really, really resonated with me. And thinking about your comments around how we need to start pushing the edges a little bit and thinking a little bit like, what is the art of the possible? And it brings me to Nikki Page and thinking about Jill's comment about how, maybe working with you allows them to push the edges a little bit. And so can you speak about how you work around the edges in support of meeting people's different needs, but in partnership with the health system, and how do you navigate that?
Yeah, I think it's kind of ironic, actually, when we think about the folks that I serve are typically considered like the edge themselves, right? So that's just a funny little tie-in. I think there's so much that goes into it that it can't really be a one size fits all, and it can't really be like a blanket statement in terms of how we foster those relationships. I don't think what works for us is going to necessarily work for everyone, but I do think one of the things that really is working for us in having maintaining these relationships and meeting the needs of the clients is that ongoing kind of constant communication. It's something Jill and I actually talked about recently, was that, professionally, it's still okay to have disagreements with your colleagues or not necessarily agree with the stance that they are coming from. And really hearing what everyone else is saying about it's about learning why they come from that stance and kind of examining the self and what's my takeaway from their stance. Am I open to hearing that perspective? Am I open to the ideas of how that can serve my clients? And so bringing it into my space. For me, the answer 99% of the time is yes, because I just want it to be better. And then I think the other piece is heavily relying on the pioneers who have really like championed the way for us to open the doors, to have the conversations, to advocate for our clients when things are not going well or they're not receiving the adequate care that they need. And I think also going case by case and examining what those barriers are, and recognizing when we see trends and when we see themes in terms of, okay, so there's not enough addictions medication specialists at the hospital at Emerge, then and there. We don't have enough liaisons to support support the clientele, but also support people to like speak medical. There's a whole language in the medical system that most of us don't understand, and that's that health literacy piece. But recognizing that not everybody has the space and grace to take that learning home with them, and that some people actually need an interpreter in the moment who can help them understand what's happening. And so how do we introduce that service into acute care and then expand it out? We know that these are already available in like a residential setting, but how do we introduce it into the acute care? And then how do we foster that continued growth? And it's entirely the work of our pioneers who have done this ahead of us. And for me, in thinking about the relationships that my workplace has, I want to take it back to that action team. And I really want to highlight the work done by one of our team members who unfortunately is no longer with us and has passed away. But Paige was amazing and championed the sectors talking to each other, and championed that social work in the hospital looks very different than social work, on the front lines out in community. And so she really took that to the healthcare system and really kind of helped them understand what they were missing and how they could approach things differently, which created a way for us to now navigate from community with social work, with hospital, with whoever, and be taken seriously. I think that's something that has been a challenge, and being taken seriously for the expertise that we have in the social services sector and in the community itself has been something. And I know the people who have come before me who have had brave, courageous, loud voices saying this isn't okay, and paved the way for me to come in and say, hey, here's this client that I have who is the living, walking embodiment of what my predecessors or what the people before me were fighting for. And they're seen and heard in a different way. There's room to grow. I'm not by any means saying that we have perfect systems, because we don't. But I have a lot more optimism and hope that there's growth that can be achieved, and that the people I care for and my clients will, regardless of every other aspect of their life, will be able to access good healthcare and good wraparound supports before my career is done. And I'm excited at being part of these teams and sitting at these tables and being able to hopefully pioneer some change for the next kind of generation of social services. I hope that answers the question.
Yeah, I mean, it really resonates to recognize all the work that's been done beforehand that now you can take forward and carry on and continue to build for the next. And it's really just also raising how, across different sectors, different professionals or just different providers, period, members of the care team work differently based in the settings and the realities and the people who they are trying to improve access for and with. And we need to actually share that and to raise that awareness amongst the health system providers across the continuum, so that the expertise in community is absolutely valued, similar to the expertise in acute care, and how do we bridge those gaps. And just thinking about conversations earlier around how, in the health system, there's legislation and there's different standards, and, community works a little bit differently. And just thinking, Jill, in terms of like, what are those governance and leadership structures that need to be in place, whether it's a formal or informal partnership when working with community, to really make sure that it's set up for success from a governance perspective. And I hear your leadership passion, so that's clear for me, but if you could explore that more, that would be really great.
Yeah, I think, again, all of these activities need to be at the outset. And so, when we think about the structures and the design of those structures that best support collaboration and partnership and team-based care and wraparound services, there has to be shared visioning and a shared agreement on outcomes. And it needs to be documented, because we know folks change, and as people change, they bring their own ideas and perspectives and experiences to the table. So I think certainly, again, speaking on the experience around EPAC and the Equitable Approaches to Palliative Care initiative generated out of UVic and then the Center for Aging, they have over the last number of years been able to capture the essence of the values, the beliefs, the structures that need to be in place. And, through different research and articles, through the publishing of the Too Little Too Late document, that provided structure that we could actually take within our health authority to say these are the areas and the issues and the gaps in service. We need to come alongside and partner. How do we do that? And so, again, I think having clear documentation around what the partnership is, who's doing what, when, and how, evaluating that, and coming back together and kind of, okay, is this working? Having, as simple as it seems, and sometimes I think we make things too complicated, we have to have ways of communicating documented. When there's a rub or there's a tension, and I can think of, and if she were here, she'd be okay with me saying this, the one of the directors for the Kool-Aid organization that we've worked really closely with in the development of the Port Initiative, there were times when she and I had to rumble. We'd have to pick up the phone because she's bringing her organizational perspective and constraints and issues, and I'm bringing mine, and sometimes they clash. And so, what do you do with that? And I think it's through that kind of collaboration and discussion, being able to be really open and honest. And this is how far I can go within the health system. This is where we can bend. This is what I can bring forward in terms of funding. And then, for the community organization to say, okay, well, I can only go this far. How do we do this together? Because at the end of the day, we have our clients, our residents, our individuals. And so when we have that shared collective around that, and that ability to be able to just have really frank, open conversations, I think is imperative. Again, though, we need the structures within the organization, and we need it documented. You need memorandum of understandings, those kind of constraints, and you need to be able to develop those in such a way that they're revisited, that they're nimble, that they can change and evolve as the service or the team evolves over time, so that you can be responsive to the unique needs of the individuals and clients. And, both Louise and Nikki George and Nikki Page have all talked about the need to be responsive to the individual needs, and those needs are going to change. No two folks that come into our services have the same needs, and how we respond to them is going to be slightly different. And our services, access to services, has to be nimble in order to respond to those unique needs that individuals have.
Thank you so much for that, Jill. Agree, and people are appreciating your openness in your approach. And I think it's also important to say that everyone brings their different perspectives to the table, regardless what the conversation is, and that you just need to find ways to work through that and come to a type of agreement so that everyone can move forward towards that collective goal. And in this case, it's about providing services and health and social services to people based on their unique needs. There's one thing that's emerged as you spoke, Jill, which we didn't actually touch on. It's about impact and evaluation. And I think that we benefit from a quick round with our panelists, but just also highlighting before I jump into that question that there's lots of support for that team-based approach to care that Nikki George really highlighted earlier in the conversation. And then that there's multiple people who contribute to that, whether it's occupational therapists or death doulas. I mean, the team is really the team, and we need to think really broadly about who is that team that is going to be there to provide care and meet those unique needs of the different individuals. So just thinking about impact and evaluation, Louise, I'm curious in terms of like, how, I could imagine that everyone's going to come with their own needs in terms of what's important to measure, what does impact look like, experience. And so what's your perspective, Louise, in terms of what's important for us to keep top of mind when evaluating these partnerships around providing more holistic care and what's important to the person and the caregiver?
Well, I think you have to look at what's working and what's not working. Everybody's going to be different, and you need to have your prem and your proms to meet funding. So, and every situation is going to be unique. So, whether it ended as a good situation or a bad situation, it was still a learning experience. It was a learning experience for the team. And as long as the team takes that away at the end of the day, no matter if the outcome was positive or negative, it's been a learning experience. And every opportunity that I attend is a learning experience, because you sit back, you listen, and when you listen, you learn. And the more learning you have, the better you can communicate with everyone else. So I think it's all about just listening, and whether it worked out it may have only worked 50%. You may have only met 50% of the needs, but there was still positive, and you learned what didn't work, and you move on and you apply it next time. And that's the only way, as long as you're looking at the holistic approach and that everything evolves, you can just listen and learn and have great communication. So it's not always about ticking the boxes, because not everybody can fit in a box, and not every box is going to be checked off. Just my words. Thank you.
It's absolutely a learning journey, Louise. Agree with you. Nikki, George, any reflections in terms of, from your perspective as a navigator, what's important for us to keep in mind?
Absolutely. And just listening to all the great words that were spoken by Nikki, Jill, and of course, Louise. And I think what really is hitting me is, that being able, and I love the word Jill, nimble, is being able to pivot when we need to pivot. Are we going to make mistakes along the way? Yeah, we are. But are we able to change course, be brave enough to change course? And, and yeah, we all need to be open, be brave to have uncomfortable conversations. And through that, as Louise says, is, we're going to learn. And with learning is that knowledge. I always say knowledge is power. But again, just, being flexible to pivot and change course when we need to.
Agree. I mean, I think the journey is also part of that impact and evaluation piece, is that learning along the way. Nikki Page, any reflections in terms of what's important to think top of mind from an evaluation impact perspective?
Yeah, I think from my end, just seeing the volume of people who are accessing healthcare is the evaluation piece, right? We're not necessarily evaluating what that looks like, but just the willingness to seek medical supports in itself is a huge win for us. So I think, from the working with the unhoused population, it's seeing that growth and seeing that increase of people accessing health and being comfortable accessing health. And a little bit on evaluating effectiveness with health coming to us instead. And I think that's what's bridging that gap, is people are accessing healthcare because healthcare is coming to them. And so just continuing to move forward and see how we can continue making it better is, I think, the piece for us. Yeah.
I love that. That helps us coming to you. Jill, reflections on evaluation.
I think there's a couple of things, certainly again from a health systems perspective, but to build on Nikki Page just a little bit, with the work that we're doing around palliative care for the structurally vulnerable population, one of the metrics that we're looking at really is decreasing hospital utilization, right? And the why of that is less about the impact on the health system and more about ensuring that an individual's wishes, goals are honored, respected, and heard. So I think, you know, at the core of the work, whether it's in palliative care or you know, maternity care, anytime an individual is intersecting with our health system, I think we need to be continually ensuring that their wishes are expressed, they're heard and documented, and they're honored and respected. And so I think there are multiple ways that we can evaluate that in our system and monitor that. And it goes back to kind of, Louise, what you were talking about right at the start. You know, it's ensuring that we are able to be nimble, we are responsive, but that we are honoring their goals of care.
I think that's really why we're all in this healthcare system trying to do better, I think. So that sums it up very nicely, Jill. Any final words from our panelists? So I'll start with Louise and go around. Louise, any final reflections from our conversation today?
Just remember, every day is a learning opportunity, and it's that knowledge that, as Nikki George said, knowledge is power. And it's that knowledge and that ability to be flexible and to use that knowledge in a holistic way.
Nikki George, final reflections?
Yeah, I was really thinking around partnerships, and some of the partnerships that I certainly leveraged working in acute care space, and you know what really worked, and really was, you know, taking that time for relationships and that communication, constant communication, and understanding it takes time. So I think there's a time commitment, and keep momentum built. And that's part of communicating, but really leveraging, you know, and understanding everybody's the common goal of the partnership, and really, and I think I said this before, is just really being open to having cross-sectional, because very different perspectives can bring in some really great ideas that you might be missing. So yeah, thank you for that.
Nikki Page?
Very hard to follow Nikki George, because I so strongly echo what you're saying. I think there's it does take time, it does take commitment. It's absolutely a journey and work in progress, and but it's doable. And I think that's something we think about these big systems, these big healthcare systems and the provincial systems, and they're scary and daunting. And that's true, but the partnerships are formable, and we can storm, norm, perform with those groups as best we can. And at the end of the day, it all works to benefit the people that we're serving in social services, and it works to set the next generation up for success. And I think that's, for me, the most important thing, is that the people who need care get care, and that we break down some walls to make sure that there's less barrier next time that person needs care, or next time, you know, their kids need care, whatever that looks like. That's our role.
Thank you, Nikki. And Jill, final reflection, over to you.
Oh my goodness. I guess ditto isn't enough. But I would say ditto. And I think my reflections are really, and when I did a quick look through the chat too, what we're talking about here today is a compassionate communities approach to care. And that compassionate communities model is often associated with palliative and end-of-life care, but really it is care, it's healthcare. It's how do we support mobilizing communities and individuals to care for each other. And the wisdom of Indigenous peoples in that, I think, is so incredibly lost. And we won't go into that today, but I think there is so much learning that I continue to do, and I think we all continue to do. So I just say thank you for this opportunity. And I want to do a shout out to Michelle, who was talking about occupational therapists and their role. And I hear you. And I actually had a conversation with an OT not too long ago about why are they not involved in palliative care. So I hear that. And I think it's a huge miss. So thank you.
Thank you so much, Jill. I agree. I mean, there's so many different pieces of the workforce, people in the workforce that we can actually tap into and that we can leverage to their full scope of practice. Absolutely. So thank you so much to all of you. So Jill, Nikki George, Nikki Page, and Louise for spending the last hour and 20 minutes with us engaging in this really important conversation about bringing together health and social services, because what I've heard from all of you is that it's actually vital. People deserve, need, should have holistic care that meets their unique needs. And the only way that we're going to achieve this is actually if we integrate together to provide these services. And I heard a lot from all of you about how people need to be brave. They need to work along the edges. They need to come at this with humility and listen. And that there needs to be an openness to work in really good ways to meet the needs of people across the country. So thank you all of you for spending the last hour and a half with us. It was really engaging conversation, and there's lots of activity in the chat. So I know people really appreciated the conversation and your different perspectives to the conversation. So with that, thank you also to the participants for staying with us on this journey. Your feedback is really important to us as we plan future sessions. So we ask that you please just take a moment to provide feedback on our 5 polling questions that will come up on the screen. So they are, what best describes your current, so there's questions around gender identity and just about the session in general. And I believe the poll will be coming up. And also, while we wait for the poll, also like to hear from you in terms of from in the chat or by email, just about different topic areas. And also we encourage you to subscribe to our HEC newsletter. So that you can stay informed about what's happening at Healthcare Excellence Canada. So once again, I'd like to thank Jill Gerke, Nikki Page, Nikki George, and Louise Bird for this great conversation, and all the team at HEC who supported us in the background. So thank you so much, and have a good day, everybody.